There are a number of commonly occurring manifestations of decompression illness. While each may present alone, combinations of symptoms are frequent and should always be actively sought and/or excluded. Limb pain is probably the most frequent manifestation of DCI. It describes a deep aching pain in a limb or joint, which may begin during ascent or at altitude. In aviators, it is the lower limbs, particularly the knees, which are most commonly involved. The pain usually begins gradually and is poorly localized. It may resolve spontaneously. Minor pain may migrate from joint to joint, a condition known as the niggles. It may worsen, becoming localized to a particular joint and acquiring a dull, boring characteristic, frequently likened to toothache. The pain is seldom made worse by movement, and often there are no objective signs on examination. Patients presenting with isolated limb pain must be fully examined to exclude any neurological deficit, as the pain may mask mild paresthesia, numbness, or weakness. Limb pain, DCI, frequently resolves completely on descent to ground level. Girdle or back pain often presents as a poorly localized aching or constricting pain. It originates in the mid to low back and often spreads, usually bilaterally, around the pelvis or abdomen in a girdle-like distribution. Occasionally, it may originate in the thoracic spine and spread around the chest or shoulder girdle. In the context of DCI, pain of this nature is associated with spinal cord involvement. Its presence may herald neurological deterioration. Involvement of the nervous system may range from the subtle multifocal presentations of mild evolved gas disease to the dramatic catastrophic presentation of severe cerebral age. Both the central and peripheral nervous systems may be involved, giving a huge range of possible neurological manifestations. These can include alterations of higher functions, altered affect, loss of memory, cognitive impairment, altered level of consciousness, seizure activity, impaired coordination, reduced strength or sensation in any distribution, presence of paresthesia, dysfunction of the special senses, and loss of sphincter control. The audiovestibular system may be damaged directly as a result of barotrauma or as a consequence of evolved gas disease affecting the cochlea. In individual cases, it may be impossible to distinguish between these mechanisms or sites of injury by clinical examination alone. Consequently, audiovestibular DCI may describe any presentation that includes rotational vertigo, tinnitus, nystagmus, or reduced auditory acuity after a provocative altitude exposure. Nausea and vomiting may accompany these symptoms, but are insufficient in themselves to imply audiovestibular DCI. Involvement of the lungs in DCI may be as a result of two distinct processes, namely decompression, pulmonary barotrauma, and the cardiopulmonary consequences of massive venous gas embolism. Cardiac involvement may also result from coronary artery age. Although the mechanisms involved are distinctly different, it may be difficult to distinguish between them in a clinical setting. Many of the symptoms and signs are shared, including dysnoia, tachypnoea, chest pain, cough, hemoptysis, cyanosis, and rarely shock. Progression of symptoms at altitude may be due to either a tension pneumothorax or massive gas embolism of the lungs. The latter condition, often referred to as the chokes, presents initially with a sense of constriction around the lower chest. Any attempt at deep inspiration is marked by an inspiratory catch. This is accompanied by the development of retrosternal discomfort and paroxysmal coughing on inspiration. Breathlessness and cyanosis follow, and, shortly thereafter, progress to collapse if the altitude exposure is maintained. Symptoms of respiratory DCI may persist for several hours after return to ground level and are thought to represent the reflex response of the pulmonary tissues to the venous gas load. Cutaneous manifestations often occur at altitude. They are usually transient and consist of itching, tingling, or formication. Occasionally, itching may be severe and accompanied by hyperesthesia. More infrequently, erythematous, urticarial rashes, or cyanotic mottling and marbling are observed, usually in conjunction with other manifestations of DCI. There are a number of nonspecific symptoms, which may be considered part of the constellation of DCI. These include headache, malaise, fatigue, nausea, anorexia, and anxiety. In a small proportion of cases presenting with these symptoms, there is progression to diminished consciousness without any other manifestations of DCI.